Good afternoon, friends. David Wright here, and I'm your host of the Disruptive Innovators Champions of Digital Business podcast. And today I am lucky enough to be joined by Dr. Ami Bhatt. Doctor, pleasure to have you on.
Thank you for having me.
Absolutely. Ami, can I call you Ami?
Yes, of course.
We'd like to start our episodes with one piece, if there was only one, because I'm sure there will be many, but if there were only one piece of actionable advice you might look to leave everyone with, what would that be?
Eventually, during this conversation, I think we'll get to AI, as most conversations nowadays do. And I would say the governance gap in at least healthcare AI, it's not at the front door. It's downstream, somewhere where you're not
Mm,
expecting it, where no one's watching. So go look there.
great advice. Excited to dig into that more. So Ami, I want to get into it. Can you talk to everyone who may not be familiar with you or your work about your current role, kind of some of the work that you're doing now?
Sure. I'm the Chief Innovation Officer of the American College of Cardiology. We are the largest kind of nonprofit representing cardiologists and other cardiac caregivers and administrators in the world. About 60,000 individuals that are members, over 2,500 health systems, and we're two-thirds US, one-third ex-US. We're really a global organization. My job, oh gosh, my job has evolved over the past 10 years that the innovation program has existed, but currently is kind of threefold. And I love it for having that tripod effect. The first is working with companies. We know that most technology that gets through the FDA for cardiovascular disease ends up sitting on a shelf. It can't actually,
Mm,
it's a beautiful technology. It can't actually get into workflow. And so our job is to work with companies, help them understand where they fit in the workflow, where uptake's going to be, how they're going to be adopted. So that's job one. Job two, creating the AI and digital health enabled clinician, because we trained the way we trained and now new things are happening. How do you now create an AI enabled clinician, people who are comfortable using the technologies that are coming at them and making healthcare better? So that's number two. And then number three is kind of a combination of things. We have a unit that invests in kind of early stage cardiovascular technology that we think is really going to be revolutionary. At the same time, we also spend a lot of time with governmental organizations doing more than advocacy work, doing governance work of how are we going to help lead medicine into the future with technology while keeping people safe. And so I like to call that part creating an infrastructure with guardrails for getting it all done. So it's tech company, it's clinician, then adopting that, and then it's some guardrails and infrastructure so that those people can do the things they want to do.
wow. Um, it's really cool to learn this today because I honestly had no idea that you guys did all that. So, excited to learn more about that. And I couldn't agree more with your first piece of advice and kind of leading into it sounds like some of the work that you guys are doing. So excited to dive more into that and the specifics of that. Before that though, I always like to learn a little bit more about you as a person, an individual, an executive, kind of how you started out in your life and your career and how you got to where you are today.
Oh gosh. I could have gone one of two directions, cardiology, which is kind of where I ended up, in medicine, um, or musical theater, which I'm now pushing on my children. But I don't think the musical theater was a real potential. It was just more like in my mind.
Mm,
I actually ended up coming up to, I'm a New Yorker at heart. Ended up coming up to Boston for college, stayed in New England at Yale for med school, and then did this residency, which is when you're in the hospital training after you get your MD, in medicine and pediatrics, thinking, you know what, if I'm going to be a doctor, I want to be the Norman Rockwell. Like you walk in the room, whoever you are, age 0 to 100, I can care for you. And as I did that, I found this group of people who were kids who had had heart disease. And now they were
mm,
approaching age 18, they were going to college, and they need an adult doctor. And the adult doctor said, I'm sorry, I don't know what you have. I didn't study that. And the pediatric
Mm,
cardiologist said, why are you 35 and sitting on a toddler stool? That doesn't seem right. And it turned out that around the time that I was graduating with my degree in medicine pediatrics, this field of adult congenital heart disease, kids who had never lived long enough before to become adults,
mm,
because of all of those advances in surgery, anesthesia, were now living, and nobody had been trained to take care of them. And so that actually, I didn't know I was a builder back then. Like now I look back, I'm like, oh,
right.
I'm a builder. I like, blank spaces. So that became my field of interest. So I studied adult cardiology, pediatric cardiology, trained, quite a long. We used to laugh like, would my kid graduate kindergarten first, or would I finally finish training? Like, it was really close at the end there. Um, but that became my field, and it was amazing because I really liked taking care of people ages kind of 16 to 30. It was an opportunity to really like show patient agency, right? And it turns out I love that. I love like empowering people to like live life and then deal with the healthcare along with it, help it guide them. And so that became my area of interest. And everything would have been awesome except people stopped coming to clinic. Because what 22-year-old wants to go see the doctor 4 hours away in Boston? So I started telemedicine because they started FaceTiming me. And I was like, "Oh god, no, don't FaceTime, like, I will get arrested, like, this is really bad, you
Yeah.
guys." And so I started doing telemedicine, and that was my intro to, okay, if you're gonna see them across the screen, now I probably need hands on them. So I need a digital stethoscope. So I started advising the Echo Health stethoscope folk. And then I started working with, companies with their handheld ultrasound and then data sharing, which now everybody, well, it's still not easy, but at least we all know what it is. Back then, sharing images, you
Right.
had to drive to your doctors, burn a CD, and like bring it back. And so that kind of introduced me to the idea of innovation or digital health. And you can then fast forward a little bit through COVID at Mass General. I was the director of the outpatient clinics. When it
Oh,
hit, they said, "Hey, does anybody know what we're gonna do?" And I was like, "Hi," like little me over here with my telemedicine practice. And so we got to expand it to everybody, right? And it was really great. And so when we came out of COVID and the American College of Cardiology had this opportunity to grow this concept of an infrastructure for digital health, or what we like to call high quality healthcare in the communities where people live. That's the North Star I give my team. If whatever you're doing aligns
mm,
with high quality care in the community where someone lives, go for it. I'm not going to get mad about it. Like, that sounds great. Um, and so the opportunity arose about 5 years ago, and it was just a great next step for me. So that's how I got here.
wow. Um, super cool. Um, and congratulations for all the like things you've accomplished to date. And it sounds like you're gonna still go and build more, right? Which is amazing.
We're always building,
Um,
aren't we? Yeah.
I think I'm kind of a builder too, so I
I see you
appreciate
that
that.
way. Yeah.
So I mean, another question I would have for you would be, along the way, was there a time that you either had a project fail, or there was a personal hardship, or like something you can think back to that was a catalyst for growth or change? Or it's, I was talking to a guy, he's the head of CX or something like that at Mercedes Benz. So he handles all the customer care and experience and stuff like that. And he's a speaker and he's on stage. And we were just commiserating about how like people would come to him and be like, "Oh, like how'd you like you're here, like you did this," but like they don't see the stuff that it took. Like for
Yeah.
me, a lot of my growth came from like pain. Like I got
Yeah.
really, really uncomfortable and I had to shift.
That's right.
So I always just like to get curious about like other people and their journey and like what, some moments for you, right? If there were any you could
Yeah.
think of or share.
I'll um I'll give you I'll give you one that's like a logistic thing, one that's like a personal like leadership development thing, and then one recent one. So the logistic thing, when you start taking care of patients at a distance, and maybe it's a little personal too, but your friends look at you and they're like, how can you be a doctor? How can you be a doctor? Your patient is 100 miles away. You're going to look at him on a screen. You're going to tell me that's good healthcare. So it was kind of the personal side of that. But the logistics side of that was I started having them send me data, right? Like connected health. And so the very first blood pressure, I mean, the number of Excel spreadsheets that my nurses and I had to go through because that was the only way we had to get people's data in. And two things happens. One is you learn that if you just throw data at your team, they will not be happy with you. The second is you yourself will walk around terrified every minute that you missed something because you
Mm.
can't. The human brain just can't do. I mean, it is scary. And so I think that was a real turning point where I understood that like more data is not better. There was not going to be a solution for several years until actually very recently, right? Until we could start to process that. Um, and so that was kind of technical growth where I almost hesitated to keep doing the thing I was so sure was right. Like I was sure it was right to see people at home. At the same time, people started wondering, I started wondering, I kind of almost shifted a little bit less towards telemedicine. And so it could have been one of those moments where I just stopped. And fortunately I didn't. And I think that's the lesson there is like I still knew there was something right, but I was willing to be careful about it. And so that was an interesting growth opportunity for me where like I could have just been someone who's like, I know I'm right. I'm going to keep doing it. And instead, I was like, hold on, let's look at both sides and not judge the situation, but look at what's the right thing to do. And so I think that's important. The second is like a total fail on my part. So when I took over outpatient cardiology at Mass General Hospital, it's not like you really run it. Your friends are heads of all the different subspecialties in cardiology. And you try and
Mhm.
convince them all to go from their really comfortable way of practice to a
Yep.
43 room, 10 admin assistants who nobody knows anybody's name at front yet, like moving people in and out, in Johnny's, whatever. And just not that like Mass General flavor of healthcare that like I went there for, right? But it was efficient. It was the right thing to do. It was a pretty new space, whatever. And I remember one of the first days I walked into a meeting and I put down a sheet of here's how it's going to be at every spot for when people sat down.
Mm.
Nobody ever teaches you how to manage when you go to med school. You just learn the science and you learn the patients. That was my biggest management lesson ever. You cannot walk into something new and tell people you know how to do it. You just can't. And young people forget that. Or we think, but I've been
Mm.
there, I know this. And the answer is
Right.
like, you may know some of it. You don't know it from the viewpoint of the humans who are going to be getting the work done. And so
Mhm.
I mean, when I think about that day, I can picture the room. I can picture every detail because it was such a like emotional moment for me of like, holy, what have I done? And I had to
Yeah.
backtrack from that. And it took some time to earn my friends, faith back and start figuring out what to work on. So, lesson learned, personal growth. Everybody's kind of got to go through it, but there will be times where you forget that you're there to collect others' thoughts, put them together, and help lead by not necessarily example, but lead by collaboration. And so
Right.
that I think that's like personal leadership lesson, like 101. You'll never forget those days. And then the little thing I'll tell you is we were at my daughter is obsessed with F1, and therefore I am now too. And we were at F1 Barcelona this year because Barcelona is going to be kind of closed down from the every year thing, and Madrid's going to be the new place. So Formula One. And we got to go to the Ferrari garage, got to see the cars. And I was talking to people about what it was like to be there. I was telling them about their wearables and other things. And all of a sudden they call me over and they're like, Doctora, come here. And they were doing like calisthenics. The pit crew was doing exercises, right, for their arms, shoulders, quads, kind of loosening up. And I thought, oh, and so many things came to me in that moment because first of all, they were so proud of what they were doing. And then I thought, one, we're protecting our workers, right, from getting injuries. But number two, if somebody who has to take a tire off in 2.4 seconds cramps up, that is a championship, that is millions of dollars, that, right, there's so many things there. And it just made me realize that there is a depth to everybody's profession or career that
Mm.
most of us don't know if we don't take the time to really spend there. And I think that depth kind of kicks off of the thing from before. which is you got to
Right.
really get to know it. And people take pride. Everybody that is a cog in whatever wheel, like everybody takes pride in what they do. And they were so proud of like that calisthenic routine. And it was really great to like be there and be part of it. So I guess that's my like idea of different things that have taught me and made me who I am today when it comes to like, leadership or how I do things.
Yeah. No, 100%. Wow, there's a lot of good stuff there. I'm trying to think of where to start. I mean, one of the first things that comes to mind, just about kind of like the second thing you said was, I'll never. It brought up this time, like one of the larger health systems that we had worked with, like early on in our time as a company, and we had this framework and this vision for what CX could be for a health system and the
Hmm.
interconnectedness of it all, and the design and the strategy and how to get there and the 60-page deliverable.
Hmm.
And I still have that visceral memory of presenting it in a conference room of like CFO, CIO, COO, et cetera, all the telco, IT, digital people, some of the ops people, and it was fine. It was fine. And they used parts of it, but afterwards, the CIO basically told me I didn't meet them where they were at,
Yeah. Yeah.
and it took a while for that to sink in because I was kind of like I just wanted to shake them. I wanted to say
Yep.
like this is what you have to do.
Yep.
Like, don't you
Yep.
know?
Yep. Yep.
Um, but that is not a effective strategy. So
Yep.
I had kind of firsthand experience of that, and then as I developed as a leader and particularly as technology has evolved so quickly in the last years, I also came to respect and appreciate the importance of having those conversations. So there was a subsequent health system where when we were doing our discovery, I think we did upwards of 100 interviews, right? Maybe 30 of them were with like IT and digital folks, and the rest were with medical group leadership, clinical leadership,
That's
like
right.
all the people, because before we started pontificating on anything, we wanted to make them feel heard, make them feel
Yes.
seen, because then when we came to any type of strategy, we could come back and say, "Hey, Dr. Smith, I know you mentioned that
Hmm.
you wanted to see this. I think this could address that," right?
Yep.
Or even
Absolutely.
like for the administrator, like, "Hey, Sally, hey, Jonathan, I know you've done the same thing for the last 20 years, and that's comfortable, but you also mentioned that like it would be nice if you could be there more with the patient. I
Hmm.
have something that might be able to help with that. Like,
Hmm.
we're going to start demos in a little bit. Would you want to be a part of that?" Right. As opposed to getting down here, slap them in the face at the demo, and they're just like,
Yeah.
the fence
No,
goes up.
no, that's right. Well, I'll tell you, I had, I was talking about how people had their kind of small groups in Mass General. So I had an admin who's with me forever. Like we grew up together. And I remember though, one day my telemedicine numbers were kind of going down. And I just couldn't understand what was happening. And I just happened to be walking past her desk. And I heard her say, well, Dr. Butt's not available in the office that day. But she's doing this new telemedicine thing. So if you wanted to try that, and just the way she was saying it, I was like, yeah, 75% chance if I'm a patient, I say no to that new thing. And so then she and I had a chat, went to coffee, talked about like how we could pose it in a favorable way and, what her hesitations were about selling people on it. And I answered her questions, totally different numbers the next month for that clinic
Yeah.
simply because she was the first line. And I hadn't thought when I was just doing it by myself about what's the infrastructure I need, right? Because I just kind of picked it up. And so I think such a great example of thinking about every step of the way, getting people's input and understanding their questions. The word that I have started using, we work with a lot of kind of big pharma technology device companies. And oftentimes on the agenda, either somebody from their side or ours will put barriers to adoption. And I'd stop
Mhm.
using the word barrier because it's
Mm,
only a barrier if you treat it that way. And so we actually say dependencies. This gets back to exactly your example, David, of who are your dependencies? Yes, you might be working with digital IT, but in order for that to work, what are the things that might change? Other people who might be key to this success, other people whose workflow might change, and you may not be thinking about it, but then that pushback might be an issue. And so we call them dependencies. And that's
mhm.
changed and softened our approach a little bit, even when we go and talk to them.
Yeah, yeah. Um, anyway, all really good points. And I could talk on this for a while, but I just think I do think it's so significant. I think it also plays into the advice that you offered at the onset of the episode from a governance perspective, right? Just the downstream implications of some of these types of technology. So, um, well, let's get more into some of the work that you guys are doing today. Before that, I do always like to ask favorite book or literary piece, either that you've read recently or your all time favorite, like anything you might want to share with us.
There's a book that I just got through. It is um, Guardian and a Thief. It's by the author Megha Majumdar. And it is this new, maybe not new actually, but it's this area of climate fiction, essentially,
Hmm.
which has really been growing. I think the New York Times did like their Sunday book area had a special on it. But it's this idea of talking about climate change, but putting it in a fictional story so people understand what's happening. And at the same time, you get your fictional story. So this is actually, it's lovely. It's a short book for those who don't have a lot of time or don't feel like they can read. Like anyone can read this. And it is, takes place in Calcutta. And it is the 7 days between when a woman, her 2-year-old daughter, and her father are going to get their climate visas to leave India to come meet the dad in the United States. I think he's in Michigan. And it's just the story of those 7 days and what happens between when they are getting the visa to be, climate kind of survivors leaving the country, and the day that they're supposed to travel. It is mesmerizing. It, you will read it in a weekend. It's just very hard to put
Hmm.
down. The vibrant description of India in 2040 and what it could be like is just, it's amazing. And you don't have to be obsessed with Indian literature. It really doesn't have anything to do with that. It's just, it's a really rich description and the character development is unreal. Guardian and a Thief by Megha
Wow.
Majumdar. I would have everybody read it. It's just magnificent.
I'm excited. We have a lot of ties to India, so mm, I was actually supposed to go a couple of years ago and things got shifted, but I would definitely check that out. So thank you for the recommendation.
Absolutely.
Mm. So, Dr. Bhatt, Ami, um, talk to us a little bit about um your vision, and I know you have multiple roles. So let's just kind of open it up. I mean, and you started talking about some of the work that you guys are doing at the onset of the episode. So maybe as an extension of that, and maybe we could even talk about some of the key initiatives you guys are working on. Just want to kind of dive in deeper into some of that
Yeah.
work because I'm very curious about it. Yeah.
My favorite right now is called Prime Heart. Um, it's an initiative through the American College of Cardiology. And the goal behind it is we are very good with tertiary and quaternary care. When you get sicker than sick, like our
Hmm.
ICUs can handle you, we can have you live longer, we can get you to a transplant, but we're very good at all of that. We're good at hospital care. Where we haven't been the strongest is looking upstream at could we have controlled your risk factors better? Could we have found that you have a genetic predisposition for something and identified you earlier and gotten you to medications or a device before you were coming to an emergency room? And that's the area where we really need to focus and can now focus because of AI and because of our ability to look through data. Part of the reason it was hard is I can't look at my town and suddenly know who needs what at home, right? And now we have so
Mm,
many better ways of monitoring people in the home, getting people tests to understand things better, going through it and understanding who's at highest risk, and then bringing them in. And so, but there's no infrastructure. We don't really have that infrastructure. We can't rely on primary care only. I mean, God bless my primary care friends. Like, how do you keep track of the whole body and all the research that's to do with every single organ? I mean, that is a hard job. So Prime Heart is our attempt to start to build the infrastructure for preventative care. And it won't just prevent cardiac issues. The same risk factors, diabetes, hypertension, obesity, smoking for
mhm.
cardiology are true for cancer. They're true for other diseases. And so that's our biggest initiative. And we're really excited about it right now.
Super cool. I have actually a couple diagrams I'll share with you from from a year or two back that we like had put together surrounding predictive analytics and stuff like that in case they're useful.
Awesome.
Um, but I love that. Um, one of the things that I thought of as you were talking, because I'm going to be 40. I just turned 30, but I feel like I'm going to be 40 any day now.
Happy birthday. You have a whole year to
And
go. Mhm.
thank you. But anyway, I travel a lot. I'm out of my routine. I'm just
Mhm.
not feeling as healthy as I once felt. And so I'm I'm starting to recommit to my health. And as part
Right.
of that, I started looking more into like uh I don't want to go so far as to say like biohacking, but like DNA
Yeah.
testing and like
Yeah.
other things like that. And it got me curious about like why we aren't doing more DNA testing of like everybody. Like,
Mhm. Mhm.
because if the prospect was, I feel like with just like standard blood testing and maybe slightly more advanced blood testing plus DNA testing, and now with the access to AI and the other studies that we have that exist
Yep.
today already,
Yep.
we could probably be saving healthcare institutions a lot of money and helping people more preemptively. I suppose
Yeah.
that's what your program is all about, but
Well, so you are hitting the nail on the head with what the goal is and what the promise is. And like anything else, when you start peeling back the layers of the onion, you're like, oh, hold on. And so
yeah,
this is the goal. When you start to do that, you quickly realize two key things, because we don't have a ton of time to go through all of it, but you can use genetics and genomics. You can use wearables. You can use prediction models from the electronic health record. You can use AI off of EKG or echocardiograms or ultrasounds or MRI to find disease earlier for sure. That research exists. The challenge becomes we don't know when, if you have an inherent predisposition to something, it might become relevant to your actual health span. Health span meaning how long you're going to live healthy. And so two things happen. One is we don't know yet that you save money because if you
mhm,
know you might have something, will you use more resources to constantly check on it when you didn't need to? That's one.
right.
Number two, do you develop even more health related anxiety than already exists with the level of mental health across the globe because you know you have something, but you have no idea when the second shoe's going to drop? And so
I heard about that.
finding
Yeah.
everybody earlier is actually a challenge. Now, having said that, I'm having lunch soon or a Zoom soon with the chief medical officer of 23andMe. They've gone through a lot of things. Now they're kind of revamping. And so she was going to update me on this. But one of the questions I have for her is like, what does the environment look like now? Right? Like how many people want to know how much? I think there was a peak in it. And now people are really moving more towards, okay, tell me about my lifestyle. Tell me what I can
Yeah.
do today to make myself have less risk of that genetic thing being kicked off. Because it's usually the two hit hypothesis. Like you have a thing, but then something kicks it off. Like when should I start? And so what I tell any tech company I meet with is if you're doing predictive analytics, if you can find me the patients At the moment where there is something we can offer in healthcare to change their trajectory,
Mm,
that's when I want you to find them. Don't find them for me like whenever, because I don't want to wait 30
right.
years. It's awful for them. It's not great for the system. Like, I want you to first thing we should target, and we can build an infrastructure off of that. So let's take EKG, for example. You can use AI on EKG, and I can know if you're going to be a heart failure patient. I can know if you have liver disease, which I wouldn't strongly recommend doing right now, but because I don't know anything about it. So I'm like, please don't put that, don't put that on me just yet. But you can tell all sorts of things. So if you can tell something and there's something I could do right now that would then
Mm,
prevent you from declining in terms of your quality of life, getting sick or dying, then that's when I want to know. And so, yes, absolutely to precision medicine, but to precision
right.
medicine right now at the time where we can act would be the best first step to help build an infrastructure. And that
Right.
you got to put into the governance then, right? Like, don't find me
Hmm.
everything all the time because access to care is so poor. I mean, how long did the average person wait to see a doctor when you get a new diagnosis? Like, too long right now.
Yeah. I started thinking about the NHS even. This stuff's
Well,
like
while you're
heady
thinking,
to me.
fun fact about
Yeah.
NHS. So, my daughter spent the year in London and her first year of college, 8 countries, 39 euros on EasyJet, like fantastic. And she learned something, I think. But when she had to use the NHS, one thing I did learn, first of all, is kind of access, timing, how long you wait, the role of the private institutions, but it also brought up the role of the pharmacist. And that I think is an area that we don't talk about enough, which is we say we don't have enough doctors and nurses for how many patients we have. But if we would include pharmacists, doulas, midwives, community health workers as our clinical caregivers,
Right.
then we might actually have enough people to treat all of our patients. And I think one place where AI is going to be helpful when we talk about its use or kind of governance is, can we start to use large language models to safely upskill people, right? Like,
Mm,
just about enough. Let me help you get more information faster so you can be even more
right.
effective in the community where people live. And so that's an area I'm really excited about us building. And it's adjacent to Prime Heart at ACC, but something we're working on. We call it the AI enabled clinician.
Love that. Um, so that reminds me, um, backtracking to what you said about the when you came to the table with the presentation about what it could look like, and
Mhm.
um, you know, n- nowadays when we're looking at central scheduling and more centralized access centers, we are seeing that if we can arm the agent with personalized, radically convenient, compassionate data, we can arm the AI with the same, you know,
Mhm.
we can actually create a very similar experience to what they had with John when they'd come to the office and he had been there for 20 years and blah 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 blah. Like, if we can arm the people or the AI with the right information at the right time,
Right.
we can create that experience,
Yep.
which is pretty cool.
With maybe a little bit more
And then
patience than a really busy person, right? Like,
right,
the ability to
and
repeat
the
yourself 10 times, like, yeah.
exactly. And the on the flip side of that, right, the person that was at the office now can actually be there with the people who are coming to the office, as
Yeah.
opposed to being doing things over here and then trying to attend to them and then doing things over here. They can really shepherd that experience, which I also think is very cool. And kind of parlaying off of that, and like one of the things that I've been really impressed about in the UK with the NHS is community care, right?
Yeah.
Because
Yep.
there really isn't there's nonprofits throughout the US that do like community care. My
Mhm.
mother's nonprofit being one of them, right? And they're struggling for trying to get funding. They're like, who knows about the efficacy of their programs, right? Because it's like kind of monitored, but kind of isn't. Like, and it's very haphazard, right? Like,
Yep.
and not
Yep.
in a, it just is what it is, right? But like, being a nationalized program, theirs is, you have a child, right? Like you,
Mhm.
like we just had, I have a 6 month old, right? So
Oh,
after you have a
congratulations.
child, right,
Yep.
in the States, a month or so later, like you're schlepping to
Yes,
New York Presbyterian with
that's
your
right.
baby to get a checkup. And like in the UK, the nurse visits you in the home. They check
Mhm.
on you, they check the environment. It's like, it's very cool. Or I was catching up with Doug Stewart. He's like the CDIO of Northwest London NHS Trust now, and he was telling me about her early in his career as a therapist. He would ride his bike to people's houses and meet with them in their
Mhm.
home,
Mhm.
and I was just like, "That's kinda nice." Like,
I
I
I
always
have to
have
say,
trouble getting to therapy. It's like a pain in the ass to, like, get all the way to the city, and, like, I've done that at points in my career, but, like,
yep,
I was like, "Wow, to have somebody come to me, like, that would be really cool." I would be that
yep,
much more apt to opt into it if it were
absolutely.
easier.
Absolutely. I mean, home visits is one of my favorite parts of like medical school and residency rotations. Scaling it was challenging. There was a group called Dispatch Health. I don't know if you're familiar with them, but I
I
visited them
do remember
in,
the name, yeah.
yeah, I visited them in Denver, and they had, I mean, this massive central board and nurses in cars kind of going from home to home, and they had a way of knowing who was most likely going to be the next sickest person. So you could then
Hmm,
reroute someone who had a, if you have a normal routine, and this is one of those things, right? If the nurse has a normal routine of seeing patients 1 through 5, but you know three is sicker, you go there first, you reroute yourself. The same's even true in the hospital right now. If I'm reading ultrasounds, I'm going to read them numbers 1 through 10. The AI already knows number seven's a problem. So why doesn't it
mhm.
consistently push up the next most important case, the next most dangerous case to make sure that we get through that? And I think those are the places where the infrastructure is a little bit missing though. We haven't done
Yeah.
that. We haven't done that across the board. And so for those who are listening, this is like my, PSA/request is, if you have the AI capability to do predictive analytics, could you even start with hierarchy for us? Because
Mm.
then we wouldn't have to worry as much in the health system about what is the new system. While we're figuring out what new deployment looks like, you can at least help us with AI in our old system. And that then gets people to buy in and enjoy AI, believe it and trust it more. So I feel like that is a part where if anybody else is interested in predictive analytics, could you start with like hierarchy would be great for everybody.
You know, I've so loved this conversation. It's kind of like gone all over the place, which is like the best kind of conversations when it just flows. So, I mean, this has been great.
Thank you for having me.
One of the questions that I'd have for you, so to kind of two to close out the episode. One would be, where do you see the future of kind of US healthcare going, or what do you think will be some of the biggest changes as time passes? Acknowledging that you don't have a crystal ball, but or even like what you aspire that it would look like. How would you answer?
Yeah, I'm going to stay with the topics that we talked about today and pull them together, which is, I think, population health, right? Like preventive care. You can call it longevity, you can, whatever you want to call it, preventive care. It's going to have to move outside the hospital system. We can't do it from inside the brick and mortar. So we're going to have to start with the remote monitoring devices and wearables and information that lives with a patient. And then we're going to have to do three things. We're going to have to figure out, okay, this is wellness. Here's how you're doing. Here's your baseline numbers. That's your preventative care. Your precision medicine, by the way, David, is your wearable gives you advice about just you based on you, right? Your blood pressure, your heart rate variability,
Mm.
and I love that your continuous glucose, not what somebody else that looks like you would have, just you. So we get that run-in baseline on everybody. We empower people to measure their numbers. We give them wellness tips when it's wellness. If they're one standard deviation off, we start to engage behavioral health, telemedicine. Here's a new app. Try this, right? A virtual attempted care, sometimes in person, sometimes not. And if you're two standard deviations away, that is where we hold your hand and we say, okay, now this is requiring actual medical care. Let me get you to the right person at the right time with the right testing because we saw this coming. And I think we can build that three-tier system, but we have to start with the technology companies and the patients in the communities where they live. We can't have it be a doctor prescribed system when we're talking about prevention. And I think that is going to empower patients to really be able to be healthier. And that's going to free up our system. Because can you imagine if I got the right patient at the right time with the right test? I mean, I could act on that like this is a cardiologist, right? And so I think
Right.
that's the future. Population health is going to be wearable based, data based, and it's going to happen with the patients in their homes. And I think we're going to see that next 5 years. I'm super excited for it.
Me too. Mm. Last question is if you could go back 5, 10, or 15 years in time, what advice would you give your younger self?
Well, you know what I learned recently is you treat yourself as if you're too young until you're too old. Everybody feels I'm too young, I'm not there yet, or I'm too old. I should have done that. And I would say if you have an idea or a thing, like you're probably really smart just on the basis of the fact that you have an idea that you think could make things better. Doesn't matter if you're in medicine or something else. Go for it. Take it, grab
Mm,
it, run with it, learn more about it, talk to people about it. But don't think that you're too young to make it happen and don't think that you're too old to get it done.
love that. That's a great piece of advice. Um, Ami, this has been amazing. Thank you so much for taking the time.
No, thank you for having me. This is lovely.
Absolutely. And to our listeners, thank you for tuning in. We will catch you all next week.